Hi doctors, it's me again, Buddy. I'll be reviewing with you today. 12.5% of the 150 AMC questions is comprised of maternal health. As found in the AMC website, you may use the following references for your review of this subject and/or the RANSCOG guidelines. Now let's begin discussing the first half of the set of questions. A 14-year-old girl presents to your clinic because she is requesting termination of her pregnancy, which is at 10 weeks of gestation. She has been living with her 21-year-old boyfriend for the last 12 months, but against her parents' wishes, however, he has deserted her on learning she is pregnant. Which one of the following would be the most appropriate next step in her care? A. Refer her for pregnancy termination based on her own informed consent. B. Get parental consent for termination of pregnancy. C. Contact the police as the sexual relationship was illegal in view of the age difference. D. Contact the Child Protection Authority. E. Refuse her request on the grounds of age. The common law recognizes that a child may have the capacity to consent to medical treatment on their own behalf, and without their parents' knowledge. According to the Gillick competence, a person under the age of 16 years is still able to give consent for an operative procedure on herself providing she is living independently and understands the potential risks and complications of the procedure. This makes the correct answer A. Refer her for pregnancy termination based on her own informed consent. It would be inappropriate for her parents to be advised of the pregnancy and unnecessary for them to give consent to the procedure, unless she gives permission to do so. B is wrong. Although the relationship is one which is illegal, because she is under the age of 16 years, they have been living together for 1 year now. The police in Australia or the various child protection authorities would not normally take action in this case. C and D are incorrect. You can read further on this in this RACGP article, linked in the comments section. Next question. A patient who has had 3 successive spontaneous abortions attends at 12 weeks of gestation in her 4th pregnancy. Her menstrual cycles have been regular and of 28 days duration. Just prior to presenting for assessment, she passed a moderate amount of blood with clots per vagina and had some intermittent lower abdominal pain. On vaginal examination, the cervical canal admitted 1 finger readily and by manual palpation showed a uterus compatible in size with a pregnancy of only 8 weeks duration. Which one of the following is the most appropriate next step in management? A. Pregnancy test. B. A serum beta-HCG level. C. Curettage. D. Vaginal ultrasound. E. Cervical ligation. Take note of the pertinent findings in this case. 1. That the uterine size is less than one would have expected for a normal continuing pregnancy. This could be due to the fact that some of the tissue has already been passed, or that the fetus is in fact dead and has been so for some time. And 2. The cervix is open. This would be consistent with the fact that some tissue has already been passed. These findings may be suggestive of incomplete abortion, an ectopic pregnancy, or cervical incompetence because of the open cervix. Incomplete abortion is certainly possible because this would explain the open cervix and the smaller than expected uterus. It could also be a complete abortion if the abortion had just occurred. Ectopic pregnancy is unlikely as the uterine size would be expected to be smaller than that of a pregnancy of 8 weeks duration. In cervical incompetence, although the cervix would be open, the uterine size would be expected to be of same age of gestation. In this case, it must be 12 weeks, not 8. The most appropriate next step in care would be to perform a vaginal ultrasound. This could show products of conception still within the uterus. D is the answer. If the uterus is found to be empty, only then will curettage be required. Speaking of abortion, please review the different types of abortion and their presentation. A 25-year-old woman, who lives 50 kilometers from the nearest tertiary referral obstetric hospital, presents because of premature rupture of her membranes at 26 weeks of gestation, 2 days ago. This is her first pregnancy and it had been progressing normally until the time the membranes ruptured. No contractions have occurred in the last 48 hours, she has been transferred to the tertiary referral obstetric hospital, glucocorticoid therapy has been given, cervical swabs collected, prophylactic antibiotics commenced and ultrasound and cardiotocograph assessments made. The cervical swabs showed growth of normal vaginal flora only, the ultrasound showed almost no liquor was present, and the cardiotocograph was normal and reactive. Which one of the following options is most appropriate regarding her subsequent care? A. Prophylactic antibiotic therapy should be continued until delivery occurs. B. Contraction-inhibiting drugs should be administered from now until established labor occurs. C. CTG assessments of the fetal heart rate should be repeated weekly. D. The white cell count and CRP levels should be assessed every 2 to 3 days. E. Labor should be induced now. This is a case of a preterm premature rupture of membranes. Bear in mind that preterm PROM may cause preterm births, infection, and premature labor. The Queensland Clinical Guidelines has provided a detailed approach in managing such condition. This include assessment WBC and CRP every 2 to 3 days to look for evidence of possible intrauterine infection. Cervical swab to exclude infection. Commencement of prophylactic antibiotics. Cardiotocogram assessment of the fetal heart rate every 2 to 3 days. An abnormality in the CTG is often the first sign of intrauterine problem such as infection. Glucocorticoid therapy, generally for 48 hours, to improve lung maturity and to reduce the risk of intracranial bleeding should premature delivery occur. Administration of antitocolytics such as intravenous salbutamol or nifedipine in order to prolong gestation and buy time for the administration of corticosteroids. Lastly, transfer to a tertiary referral facility with a neonatal intensive care facility. Among the choices, the correct answer is D. Please make sure to review this guideline in your spare time. Link is found below. Next question. A 29-year-old woman presents with a moderately severe pain in her left groin and thigh and with some swelling of her left ankle. She has recently arrived by air travel from overseas and is at 18 weeks of gestation in her second pregnancy. She hit her left knee on a table yesterday. Her first pregnancy was normal except for the development of some symptoms believed to be related to pelvic symphyseal separation from about 28 weeks of gestation. Which one of the following is the most likely cause for her pain? A. Symphyseal separation. B. Prolapsed L4 or L5 intervertebral disc. C. DVT of left leg. D. Excessive strain placed on her leg during her house cleaning. E. A trauma to the leg when she hit it on the dining room table. All of the choices could cause pain in one leg, however, only DVT following recent overseas air travel would be expected to result in edema of that leg and account for the swelling described. C is correct. Next question. A 19-year-old woman at 39 weeks of gestation in her second pregnancy is admitted to hospital because of severe abdominal pain, vaginal bleeding of 900 milliliters and uterine contractions. Her previous baby was delivered vaginally, without difficulty, after a 6-hour labor. At the time of her admission her BP is 95/50 mm mercury, and pulse rate 120 beats per min. The uterus is palpable at the level of the xiphisternum, is firm and acutely slender to palpation, and fetal heartbeats cannot be heard on auscultation or Doppler assessment. The cervix is 3 cm dilated and fully effaced. Which one of the following, in addition to immediate resuscitation, is the most appropriate next step in management? A. Cesarean section. B. Oxytocin infusion. C. Amniotomy. D. Ultrasound examination of the uterus. E. Vaginal prostaglandin. The clinical features detailed in this case indicate the diagnosis is a severe placental abruption resulting in fetal death and maternal shock. When the baby is already dead, cesarean section is rarely performed in Australia, and the appropriate management is to expedite delivery, treat the shock by blood transfusion and exclude any coagulation disorder resulting from the abruption. An amniotomy is usually all that is required as the uterus is usually very irritable and spontaneous labor almost always follows the amniotomy. Spontaneous labor would likely follow. Vaginal prostaglandin, ultrasound examination and prostaglandin are unnecessary. C. Amniotomy is the next step. Next question. A 25-year-old nulliparous woman in spontaneous labor at term has shown no progress during a 6-hour period, despite having her membranes ruptured, syntocinon infused and epidural anesthesia employed. The cervix has failed to dilate beyond 4 centimeters, the fetal head is at the level of the ischial spines, and she has been diagnosed to have obstructed labor. Which one of the features listed below is most consistent with this diagnosis? A. Lack of molding but caput formation of the fetal head. B. Edema of the cervix. C. A progressive increase in the fetal heart rate to a level now of 168 beats per min. D. The bony head is at the level of the ischial spines. E. There is 4 centimeters of head palpable abdominally. The feature most consistent with obstructed labor would be the finding of 4 centimeters of head palpable abdominally, although the bony head is at the level of the ischial spines on pelvic assessment. E is correct. When prolonged labor occurs and progress is slow or absent, the clinician needs to perform a pelvic vaginal assessment to define if this is due to obstructed labor or inefficient/incoordinate labor. The features of each are detailed in the table. For obstructed labor, there's molding of the fetal head, caput formation, cervical edema, fetal tachycardia, a higher station of fetal head, and a head palpable above of more than finger breadths. If, however, on pelvic exam, there's no molding, caput formation, cervical edema, then it could be that that's inefficient uterine action or labor. Others could be associated with inefficient or incoordinate uterine action or labor. Next question. A 21-year-old nulliparous woman presents with lower abdominal pain at 15 weeks of gestation. Her temperature is 37.8 degrees Celsius. She is otherwise well and eating normally. At the time of her previous antenatal visit at 11 weeks of gestation, her uterus had been found to be retroverted but of the expected size. Which one of the following is the most likely diagnosis? A. Impaction of a retroverted gravid uterus. B. A urinary tract infection. C. A complication of a corpus luteum cyst. D. Tubal ectopic pregnancy. E. Acute appendicitis. All of the diagnoses detailed in the responses can cause lower abdominal pain in pregnancy. A. Impaction of a retroverted gravid uterus may occur at 15 weeks of gestation but is unlikely to be associated with a temperature of 37.8 degrees Celsius. Instead, it may cause acute urinary retention. Corpus luteum cyst complications usually result in symptoms much earlier in pregnancy. D. Ectopic pregnancy will almost certainly have become evident prior to 15 weeks of gestation. The most likely cause would be a urinary tract infection. The answer is B. Acute appendicitis is much less likely than a urinary tract infection to be the cause of the pain. To watch the next set of questions for maternal health, click here.